Hello everyone, this is Professor Williamson and this is a audio presentation to accompany the lecture for chapter 18 and chapter 19. Chapter 18 is focused on the male reproductive system and chapter 19 is focused on the female reproduction. Just to note that this presentation, this document, and this audio is a supplement. It is not to be used as a substitute for reading and studying from the text in the textbook chapter, but it's just a way to provide an additional course element, especially if you're someone who likes to perhaps have what's more close to what you might get in a classroom face-to-face presentation. So if we look at the male reproductive system, again, as an anatomy review, you should understand the functionality of this particular system and also the anatomy of this particular system. There's a picture here on this document. There's also a picture, a graphical picture of the male reproductive system in the textbook. And you should be familiar as a coder with the major organs of this particular system. As noted in the textbook, the primary reproductive organ from a functionality standpoint in a male is the testes. And anatomically, most males are born with two of them. So from a coding standpoint, if we look at the common root operations, they obviously would relate to the organs of this particular system. Some of the common root operations include circumcision, vasectomy, which are typically, vasectomy specifically, are typically coded to the root operation of occlusion. And again, if we look back at our coding process, when we coded any procedure, the root operation is tied to the intention. So the intention of a vasectomy is to occlude sperm flow. Therefore, the root operation is occlusion. However, there's different ways, and we'll see this again in the female reproductive system. There's different surgical ways that can be facilitated. So they can cut, they can tie off. So the intention is the key component, not necessarily the method. And again, we will see this when we look at the female version of the same idea of occlusion of female reproduction. Circumcision is noted as surgical removal of the top of the glans penis, typically coded to the root operation of resection because they consider that a separate body part in ICD-10 PCS coding system. The movement of undescended testes is coded to the root operation of reposition because the child typically is born and the testes do not descend in a normal time frame, and the surgeon goes in and moves them. That would be moving something back to its right and correct anatomical position. From a clinical standpoint, there are various locations that these undescended testes can stay in. So, you may see abdominal, inguinal, etc. But again, it doesn't change the root operation because the intention is the same. The other common root operation that you may see related to this area of the male anatomy is the removal of a prostate gland. The notation that you need to make in your mind and in your textbook and your coding manual, you might want to jot it down because you can make some minor notes in your coding manual for the purposes of taking a national certification exam, is that when a physician removes the prostate, one of the most common methods of doing that is something called a TURP, a transurethral resection of the prostate. However, when we look at that procedure in depth, it typically does not involve or end up with the entire prostate gland removed. They take out a lot of it, but not all of it. Therefore, per the ICD-10 PCS world, we can't code that to resection because that doesn't meet our definition. Even though the word resection is in that acronym, we can't make that presumption. Because when we read the clinical information, that's often what's done. It's really an excision. So you need to be careful. Again, way back in chapter 1, I believe it stated that the physicians can call something a resection all day. Doesn't matter if they truly aren't removing all of the organ or body organ that were decided is one body organ, then we can't code it to that. And typically, as a matter of clinical practice, you will find that physicians often call any type of removal, when they got to go in and make a cut, they're going to call it a resection. That's just how they talk. So be careful with TURPs. And if it's a laser prostatectomy, then it would be coded to the root operation of destruction because of our definition. When I say R, I'm talking about coding. The ICD-10 PCS definition of destruction and that use of the word laser. Body part values, there's a notation about there are some combination of structures. So sometimes if a patient is having the same root operation done on more than one structure, there may be a combination body part value. For example, you have the M body part value is the epididymis and the spermatic cord. You also have the ability to identify the vas deferens bilaterally, the body part value of Q. So if you are seeing, a physician is doing a procedure and you're seeing that it's on more than one body part, but it's the same root operation, you may want to look. If you don't get that in the alpha index, when you get to the table, you may want to note that to look to see if there's a combination, one body part value character that identifies more than one organ. Also, surgical approaches. There's various methods to do something. Again, for a removal of a prostate gland or part of a prostate gland, they can do a TURP. They can also do that at open surgical approach or suprapubic. All of that depends on the patient's anatomy. Sometimes it depends on adhesions the patient may have from previous surgeries. So doesn't mean that all removal of prostate glands are going to be a TURP. It could be an open procedure. Devices common to the system are those that are performed with a male are typical devices that are inserted for drainage, delivery of radiation therapy, and infusion. We also will see device values that are also for the occlusion of tubular body parts such as extraluminal and intraluminal. Remember back in chapter 1, they have pictures, but extraluminal means outside. We're putting a device outside of a tubular body part or a lumen. Intra, I-N-T-R-A, means inside of the tubular body part or lumen. And qualifier values, again, this is the same for every other system. The X qualifier value is used for a biopsy or for something that is noted in the clinical record as a specimen that's being sent with the intention of getting a diagnosis. So the most common way that could be documented is sent to pathology for analysis. That doesn't mean that's the only way it could be documented, but a physician has to be taking this specimen from the body, sending it to pathology, one component of that, but the second component has to be there for us to code it with an X qualifier, and that component is that the intention of sending it to pathology is that we are looking, a physician is looking for a diagnosis. Just the fact that something's being sent, a specimen's being sent, being removed from the patient's body and being sent to pathology does not in itself, by itself, that does not equate the procedure being diagnostic in nature. What I often say and what you have to think about is when the patient was wheeled into the OR, is there some documentation in the operative report that tells you that this procedure was in part looking to give a diagnosis or confirm a diagnosis? If that's not the case, if the patient already knows that, if they already know the patient has cancer, they already know the patient has a benign tumor, then your procedure is not diagnostic in nature. Yes, they're going to send that mass that they removed from the patient's body to pathology, but they already knew what the mass was before they began the procedure. There's a variety of ways they can do that, knowing it. They can know it obviously by doing a biopsy before this procedure, the one that we're coding today. They already did a biopsy 2 weeks ago. We're not coding that. Sometimes they make the diagnosis based on radiology and labs. So they already know when the patient comes into the OR, and they're not looking for a diagnosis. And then we also talked about bypass back in chapter 9, specifically when we talked about circulatory system, but typically when we're coding bypass procedures, the qualifier value is the body part bypassed to. There is that exception back in the circulatory system. But in every other system, it's bypassed to is what we're reflecting with the qualifier body part value. So again, the reminder, don't forget to do your, or look at very carefully, take some time. Look at the code building exercises at the end of chapter 18, and do not neglect to do the procedure statement coding exercise at the end of chapter 18. There's 10 of them, starting with the retropubic total prostatectomy. And then you have the case studies. Remember that the odd numbers for every exercise in this book, the odd number exercises are given to you in the back of the textbook. The even numbers, excluding the ones that are part of a graded assignment, are provided for you in this course. Moving on to chapter 19. Chapter 19 is focused on the female reproductive system. Again, you should know, be familiar with the functionality of the system and all of the organs that comprise or compose this particular system, such as the ovaries, the uterus, the fallopian tubes, endometrium, the cervix, etc. The primary reproductive organ in a female is the ovary. And again, just as in the male, the female has, anatomically, 99% of us are born with 2 ovaries. Also, something you might not remember, so to speak, or you might need a refresh on, is this idea of the vestibular glands, which is an anatomical term that's used, and that equates to 2 particular components, which includes the Bartholin glands. In your textbook, they give you a picture of those particular glands in figure 19.2. I didn't include a picture specifically of that of those particular glands. Also, anatomically, it's just interesting to note, to make sure you again put this in your thought process. When we look at the female anatomy, reproductive anatomy, the cervix is one body part and the uterus is another. So you will note that when you look at the body part values in table 19.1 specifically. Common root operations related to the female anatomy include sterilization. There's a variety of ways that can be done. One of the more common ones is occlusion of the fallopian tubes, which can be done by using different types of devices, including sutures, clips, or rings. Again, just like in the male, The intention of occluding the fallopian tubes is to occlude them, to stop flow. How they do it still relates back to the word or the root operation of occlusion. If they use some type of sealing, cautery, they use a clip, they block it with a band, or they cut it and tie it. They tie the two so there's no longer this connection. Those all would equate to the root operation of occlusion. If the method of occlusion is taking out the entire fallopian tube, they remove it entirely from the body, that does change it to the root operation of resection, because that's the fallopian tube, and you do have two of them, but the one fallopian tube is considered a singular body part. So if the entire body part is removed anatomically and per ICD-10 PCS classification, that would equate to the root operation of resection. And this is a picture of the laparoscopic procedure of working on this occlusion of the fallopian tubes. Often women will have this sterilization done and then they want it reversed. They change their mind, their life pathway changes, and they want to have a reversal. Typically, in layman's terms, we call it a reversal. It is clinically called a tubal anastomosis. So they are now putting the fallopian tube back together. That particular procedure is often going to be coded to the root operation of repair. In this procedure, the physician removes the blocked or previously ligated portion. This picture is one that was ligated. It was cut. A piece of the fallopian tube was taken out, and these two ends were sutured. Now they're going to take those sutures off, and they're going to use a wire, and they're going to pull this fallopian tube back together. It's going to be shorter, but they're going to remake a connection. Another common operation for the female anatomy is the suturing of the pelvic fascia surrounding the vagina. This is typically done for a patient that's typically older or perhaps has had some obstetrical trauma, and the patient has a prolapsed bladder or rectum. So these are pictures of the normal anatomical picture, and then when a woman has a prolapse, things are moving into, they're coming down out of their normal position. This one here at the bottom is the prolapse of the uterus and the vagina. So we can have this suturing method that's coded to the root operation repair. Sometimes, depending on the severity of the prolapse or the not so secure suture, sometimes they will use a mesh material. If they do use a mesh to achieve the same type of repair, the root operation then changes to supplement. If a patient is having a procedure where they're going to close the vaginal canal, the colpocolysis, that root operation typically would be occlusion. This procedure is performed to treat uterine or vaginal vault prolapse in patients, again, who are typically elderly. This operation is closing the vaginal vault using a vaginal approach. The next operation that you might see in the female anatomy related to that is something called a LEEP, L-E-E-P. It's a loop electrosurgical excision procedure. It does use a device. Something is done. A tool is used. There's also some element of laser to remove tissue. This procedure relates to the root operation of excision. In this procedure, in the LEAP, they are removing a small cone-shaped sample of tissue from the cervix, and they typically are looking for a diagnosis. This is typically something that's done after a woman has had a positive pap smear, and they're looking to rule out cervical cancer. And the root operation is excision. Next one is endometrial ablation. There's different kinds of ways that the endometrial ablation can be done. There's a procedure called a NovaSure. There's the use of the balloon, and we can also use hot water, hydrothermal. The other method is also cryoablation, which is cold, freezing the tissue. If a biopsy is done, an endometrial biopsy or uterine curettage is done as part of this procedure, then the root operation changes to extraction. Also, if a patient has an endometrial biopsy, it is considered a stripping of a lining because the endometrium is a lining of the uterus. So anatomically, this is considered a stripping, and therefore it is coded to the root operation of extraction. Marsupialization of a gland can be coded to the root operation of drainage if they incise the gland and then just drain out the contents, which is what is pictured here. If they then go in and take out the sac of the cyst, that would be root operation of excision. It is possible to code both drainage and excision if both are done. But remember that a cyst is not solid. A cyst is basically a sac that has contained fluid or sometimes a little bit of tissue, sometimes mucus in certain anatomical locations, but in this case, in the vagina area of a woman, this is typically contains some type of what we call purulent fluid, which is an infectious type of fluid, and the removal of it could just be draining it. They just make an incision and drain out the tissue, and they suture it back up. Sometimes if it's a large sac, they'll take out the sac itself, and that would be coded to the root operation of excision. Just some terminology review. Make sure you can define certain terms in this particular chapter. What is a LEAP? What does the abbreviation stand for? What is a cervical conization? What is a cervical cerclage? Also, again, as I stated, the uterus is one body part, the cervix is another. From an ICD-10 PCS standpoint, there are two separate body part values and considered unique body parts. Next thing to talk about is a hysterectomy. There's different kinds of hysterectomies. From a terminology standpoint, a total hysterectomy means the patient has the removal of her uterus and her cervix. There can be a subtotal hysterectomy, which means just the uterus is removed or just the cervix is removed. The word hysterectomy relates to the uterus and the cervix. If the physician documents the patient is having a hysterectomy, that does not mean, if that's the only terminology used, that the woman had all of her reproductive organs removed, including her fallopian tubes. So in order for us to code a total removal of all of the reproductive organs, cervix, uterus, and the fallopian tubes, and the ovaries, we have to have it documented as such. It can be documented as a total abdominal hysterectomy with a bilateral salpingo-oophorectomy. That means the woman has had the removal of her uterus, her cervix, both of her ovaries, and both of her fallopian tubes. It also can be abbreviated as TAH-VSO. This procedure requires 4 codes. You got 4 distinct body parts. You've got 2 ovaries and 2 fallopian tubes, and we do have the ability in our coding system to reflect the 2 ovaries bilaterally. We can reflect one body part value for bilateral ovaries, and another code is for the bilateral fallopian tubes. That's via the abdominal approach. They're cutting into this woman's abdomen to remove all of these organs. Now, that is not the preferred method because they want to do it typically with an endoscope. As they do it with an endoscopy, it can be less trauma, less recovery time for the woman. If they typically are going to remove, depends on the various factors, but sometimes they will do it vaginally. They're taking out some of these organs. Sometimes they do this for the subtotal. So they're just taking out the uterus and the ovaries. The uterus and the cervix. They're not touching the fallopian tubes or the ovaries. They can do it vaginally. What you see more often is laparoscopically or the laparoscopically assisted vaginal hysterectomy. And they also remove the fallopian tubes and the ovaries. And they also have this idea of endoscopic assist. This is what this is here. And this is the only body system that has this body part surgical approach value. And that's typically done for the hysterectomy. So just note that they're removing the cervix and the uterus through the vagina. Then they're going to make some small incisions, which are percutaneous, and they're going to use the laparoscope to help achieve this. Now, if it's documented, just one caution again, if it's documented as laparoscopic assisted vaginal hysterectomy, that means they just removed the cervix and the uterus. We would need to know from the clinical information if we wanted to code removal of the ovaries and the fallopian tubes. Because again, this word hysterectomy equates to only removing the cervix and the uterus. Also unique to the female reproductive system is one particular device. The pessary is an instrument placed in the vagina to support the uterus or rectum or as a contraceptive device. There's different types of this particular device. There's donut, there's ring, there's something called a gel horn. And that could be a device value that we would reflect as a positive because it's left in the patient. Or something could go wrong, or the patient wants it removed, and the physician goes in and removes it, so we would also reflect it as a positive. Another device that sometimes a physician will place is an IUD, and that is a type of contraceptive device that we would need to also reflect as a positive value. So that's the conclusion of this presentation. Again, please make sure you're reading and studying the text or the written words in chapters 18 and 19, and of course doing the exercises, looking at the code building exercises, and then doing the non-graded assigned exercises at the end of chapters 18 and 19. You have the 10 procedure statement coding, starting with a vulvar biopsy and ending with a uterine cavity sounding, an endometrium cavity curated for tissue sampling. And then you have your case studies at the end of chapter 19. The first one is a retropubic uteroplex with a cystocele repair. going all the way through to operative report number 8, which is a laparoscopy with a right ovarian cystectomy. Again, your odd numbered exercises are provided to you in the textbook, and the full answer key, which includes the even number exercises, is provided to you in the class unless they are part of a discussion board or a graded assignment. If you have any questions on this presentation, you can inbox me in Canvas or send me an email at my pipeline address.